Raptors. My name is Liz, and I'm here with my cousin Michelle. And we're here to kick off a series of interviews with Dr. Alan Green. Dr. Green is infamous for being the pioneer to prescribe rapamycin, my favorite drug, to patients for preventing disease and potentially extending health span and lifespan. I learned about Dr. Green from Peter Attia way back before he was as famous as he is now. He was on a Joe Rogan podcast, and he talked about rapamycin. He said that he was really excited that it was the best Christmas present he ever had to learn that there was a drug out there that enhanced immunity in elderly patients. That was really exciting to me too, because I had been diagnosed with an autoimmune disease, and that was what really caught my attention. So I looked up this doctor, I found his website, and
you were on a plane the next day.
Yeah, pretty much as quickly as I could make that happen, I was. And when I got there, actually, the plane the next day didn't come from the immunity issue. The plane the next day came because I also learned that not only was rapamycin enhanced immunity in elderly people during a study with the flu vaccine that was given. I learned that rapamycin had been shown to prevent and in some cases reverse some signs and symptoms of Alzheimer's disease. And to me, I felt like I had found the jackpot. It was so serendipitous. And the reason why I felt that was because Michelle and I both carry an APOE4 gene. We're cousins, and so her mother and my father's side of the family definitely have carried the gene and passed it down to several of us. And it was
all of us, I believe all of us have at least one copy.
Yeah, I think all of us have at least one copy, all of the grandchildren. So in any event, I was super excited about the prospect of there actually being something out there that could help us. And I read about the studies with the mice and the fact that, these mice were either not getting Alzheimer's disease, and the ones that they tested with Alzheimer's disease were actually improving. They were improving in their functions. So it was wonderful to meet Dr. Green. I've been taking rapamycin since 2018. I feel well. I feel like my immune system function, maybe it's improved, but it certainly has not gotten any worse. And that's great because it's a chronic progressive disease that hasn't progressed as far as I can tell. So in any event, we're going to be talking to Dr. Green quite a bit, and I'm going to pass this over to my cousin Michelle so she can tell you a little bit more of what we're going to be doing.
Sounds good. Hi, everybody. Hi, Raptors. I'm one of Dr. Green's more recent patients. I was very hesitant when my cousin Liz first went on rapamycin, despite a lot of research that you did. I mean, you were one of Dr. Green's early patients. What number were you? 160 something, right?
162, I think. He's got
162.
12 almost 1,300 now, I think.
Mm-hmm. So he's going to tell his story. We're kind of introducing the patient number one podcast, which is obviously Dr. Green. He was patient number one after discovering rapamycin and then taking rapamycin, extending his life by a lot. I mean, he started at 72 years of age, thinking he was dying of aging. lo and behold, he did all this research on aging, found rapamycin, found all, knee deep into the research, and then later discovered he had a very rare cardiomyopathy that would have killed him very quickly. And so he describes it as he describes aging. It's really two sides of the same coin. Aging and age-related diseases are really the same thing. And what he's going to talk about is how rapamycin targets that coin on both ends, because it halts TOR, which is the target of rapamycin. So it's an interesting story. I was very skeptical when you started taking it in 2018, 5 years ago.
Yes.
Yeah. Despite, I had a lot of respect for all the research you did, Liz, because you really did the same. You lived and breathed Alzheimer's, and what to do about it. You really
I was scared. It was devastating to see my brilliant father and my dear aunt go through what they did. And I didn't want my family to have to see me go through that.
Yeah, they died very young, and this disease runs very deep in our family. So we really should all be concerned, and it really should be on all our radar, if there's anything we can do about that. But the mainstream thought is like, there's nothing you can do other than, there's a lot of hype around lifestyle, healthy diet, exercise, keeping your brain active, which are all things that I try and do. And I thought, okay, I'm doing what I can. And I'm very skeptical of pharmaceutical drugs, because I know a little bit too much. My career has been in the healthcare industry, not as a clinician, but as in sales and ancillary and, management and that kind of thing. So I'm very aware that, when there's no money to be made,
there aren't going to be any clinical studies.
There's not going to be any clinical studies, and the information is going to be suppressed. It's not going to be out there. So, and rapamycin just honestly also sounded too good to be true, So I just kind of sat back and waited. I honestly thought that maybe there would be some really negative side effects that you would experience after a couple years or longer of taking the drug, but all I saw were good things, all I saw were benefits to you. So when I this past year, started really feeling some functional decline with aging, nothing serious, but just the usual. When you hit midlife, things start to creak, and you start to get the body pains, and you start to think about your mortality. And I don't know what happened. I think that I ended up watching that Peter Attia podcast on Joe Rogan, which he actually said verbatim, rapamycin is his favorite drug on the planet. Maybe on the planet. I don't know if that's verbatim. He says it's his favorite drug in the world. He mentioned the Joan Manick study that came out on Christmas Eve, which he thought was the best Christmas gift ever, because that was an actual study on humans. Thus far it's been on animals, right? On mice and dogs. There was the one study that you took part in of Dr. Green's patients, which was simply self-reported symptoms.
That was a survey.
Right. Yeah. But they found
and that came way after the podcast with Joe Rogan. That was
right.
Just, within the last year or so, they completed that study. And the Joe Rogan podcast was probably in 2018.
Right. So that really kind of legitimized it for me, because, I figured if Peter Attia is advocating for this drug, that's pretty huge. And then I started doing my own little research, a lot of listening to Matt Kaberlin, who's really the #1 guy in rapamycin research at this point, pretty much, right? So he's
would
done a
say
lot of
so.
mice, right? And they, I watched, he has a podcast with Peter Attia, and they both pretty much admit that they take it. They're not giving medical advice because it's not approved. Well, there aren't enough human clinical trials for them to be convinced that they should actually be advising rapamycin. But hey, if it's good enough for them, that says a lot. So you finally got me, Liz, and I started taking it not too long ago, and I feel good. I don't know, it's not something that you're going to feel dramatic effects from, but I think there's a little more spring in my step. I think I've lost a little weight, not really trying at all. Yeah, so I'm happy with my decision. I feel good about it. I don't feel any hesitation or fear. So it's all good. It's all good. And then, Dr. Green reached out to you because he's 80 now. He's been on rapamycin since he's 72, and he tells his story, which is really fascinating. And, I'm sure he had a death sentence, basically, that he found out after the fact. He would not have been alive today without rapamycin. There's no doubt in my mind. I think none in his mind or yours. So really, he runs his rapamycin practice. It's just him. He has plenty of patients because patients seek him out. All the people that are doing all this research. He doesn't need more patients. He really genuinely wants to impart his wisdom and knowledge about rapamycin because it's not out there, because there's no money supporting the data that we already know. And there's no money supporting, let's get human trials out there. So that's what he's doing. This was pre-recorded, his story, because we're just kind of throwing this together. We don't know what we're doing. It's really bad.
Nope.
It was really bad, but we're reintroducing it. I kind of edited it down, but he tells his story. He talks a little bit about the APOE for gene and how that relates. There's so much more with rapamycin. We're going to talk about his theory of aging, which stemmed from his research with Dr. Michael Blagasklani. And he talks about Dr. Blagasklani and who he is. Liz, correct me, please. He's an MD researcher, MD PhD researcher. He deals with mostly cancer, but he's the one that basically connected TOR with
Aging,
right?
Mm-hmm.
Yeah. So he's big in the TOR and the rapamycin. And I think, was he the one that kind of perfected the dosing protocol, or was that other scientists? Do you know?
I think he wrote a lot about it, and he also made the distinction between mTOR C1 and mTOR C2, which matters with dosing. So I think, yes, Dr. Green essentially implemented information that Mikhail Blagasklani had presented in his practice.
Okay.
And one of the other things that I think is important to mention is that if people have Alzheimer's disease in their family, taking a drug like rapamycin that has very few, if any, side effects in my mind, it should be a no-brainer, because the alternative is horrible. And not only does rapamycin work to prevent neurological diseases like Alzheimer's, it also prevents cardiovascular disease. They've even shown in some recent studies that not only does it prevent, but it can reverse certain things like periodontal disease, I believe cardiomyopathy. It can help reverse that to some degree. I don't know all of the research that's been done, but certainly there are plenty of university level, studies, and you could almost look up anything and see if rapamycin has ever been studied with regard to that particular dysfunction. And it's surprising how much there has been. I think it's an easy target for research. People who are, trying to get their PhDs and need to do something. There's really a lot out there.
Yeah. Well, and especially the big four, excuse me, big four: Alzheimer's, cancer, cardiovascular disease, and diabetes,
metabolic disease,
metabolic dysfunction, as well as rare diseases. I mean, basically, I think we're finding that a majority of these diseases are age-related diseases that are
impacted by TOR,
affected by TOR. So, so Dr. Green wants to talk, drill all these down to, specific topics and talk about all of them specifically in each podcast. So we're going to talk about all those diseases. We're going to, the next podcast is going to be on his theory of aging, which is derived from Dr. Blagasklani, I believe, which kind of upsets classical theory. And it's the reason that rapamycin works. Also, yeah, the dosing protocol, the immune function, the innate versus acquired immune system, why the dosing works, side effects, yeah, which are minimal. So here is Dr. Green just basically telling his story of how he came upon rapamycin. Essentially, the way I look at it is that, he just thought he was dying of aging and had nothing to lose. He researched aging. He's like, I have nothing to lose. I'm going to try rapamycin. And then, everything kind of unfolds from there. So it's fascinating. He's he's very funny too. You got to kind of pay attention closely because he puts these little zingers in there,
Yeah, he does.
Yeah.
He does.
Okay. Anything else before we
say no, it's good.
All right, everybody, if you have any comments or questions, please feel free to put them in the comments. That's what this is all about. We're just discussing. Dr. Green will be answering questions, and we look forward to it.
Learn something today. Thank you, Michelle.
Here's Dr. Green.
I started med school at age 20, and I retired from medicine about age 62. And during that time, I had zero to anything to do with aging. So there's two things to understand to make the story make sense. Is that when it all started, I had I knew zero about aging. And the other thing that makes it make sense is when I retired, I had poor financial planning, and I had way too much income. And the year I retired. So I didn't say 10 years later, when all this started, I had no medical insurance. So it starts with that, me having no medical insurance and me and knowing nothing about aging. However, at age 72, I notice I'm having a very, very sharp decline in my health. I'm having such a sharp decline in my health that I conclude, and actually it turned out later that I was right, I was not going to live very long. I figured I wasn't going to make it to age 75, and I was convinced that I was dying of aging. Now, if I had had health insurance, I guess I would have seen a cardiologist, and he would so forth, but I didn't see a cardiologist. I just assumed I was suffering from aging. But as I said, I knew nothing about aging. So my response was like the response of a usual pathologist. If I was dying of aging, I wanted to know something about it. So I started, so at age 72, I started studying aging. And that was like, so the first thing I encountered studying aging was the whole field was just junk science. Now, I didn't know anything about aging, but I had been in science for 40 years. I knew science was when it made sense, and science when it was junk science. However, well, that's for a later story. However, when I did start studying aging, what I did come across was Mikhail Blackaskeleton. Now, Blackaskeleton was an absolute giant, and he had an extraordinary original theory, totally different than anybody else's concept of aging. His concept of aging was that something called mTOR, T-O-R, the M standing for mechanistic. mTOR was driving aging. That aging and age-related diseases was essentially two sides of the same coin. Not only that, there was a drug around called Rapamycin that blocked mTOR. Blackaskeleton presented the idea in a paper going back to 2006, Aging and Immortality, that mTOR, that rapamycin would block aging, and you could take rapamycin because it was a drug on the market. However, at the time, at that point, it had been approved as a biologic poison in 1999 and to be used daily, and used daily, it was way, way too dangerous with too many side effects. Anyway, so this year, the year I started studying it, 2015 was a very, very good time to start studying aging. So it wasn't because Blackaskeleton had developed a very robust theory of what was going on. He had more than a dozen papers. He had hundreds of references. It was a very good time to study aging. So I basically studied all Blackaskeleton's papers. I was extraordinarily impressed with him. I copied hundreds and hundreds of his references. He had hundreds of references in every paper. I studied thousands of references. And within a year, I basically knew all the stuff there was to know about rapamycin and his theory of aging. But the idea was how to use it. However, just about that, because it was thought that it depressed, because its use in transplant medicine depressed T cell function, depressed the acquired immune system. Depressing T cell function would be extraordinarily dangerous. Nobody would want to do that. T cells are sort of like very important in cancers and ailments, very important other things. Depressing the activity of your T cells would be real bad. However, about this time, it started emerging, and there was a huge mystery at this time, because after Blackaskeleton in 2000, theory in 2006, in 2009, it was shown that rapamycin was increasing the lifespan of mice by 10 to 12%. And in 2014, it was increasing the lifespan of mice 25%. And by this time, all sorts of basic people in research were studying rapamycin for all sorts of diseases. And they were finding that all sorts of age-related diseases, mTOR was at the center of it. And reducing mTOR was real beneficial. The problem was, why did people in transplant medicine not have any benefit? But it looked very good in mice. It looked very good in basic science, but people actually taking it for transplant had no benefit and did not have any increase in lifespan, had like more risk of previous problems. But then about this time, other people figured out that there was two components. There was mTOR1 and mTOR2. And it turned out that all the benefits came from reducing mTOR1, and all the harmful effects came from reducing mTOR2. So the trick was, how do you take rapamycin and reduce mTOR1 and mTOR2? And about this time, other people in sort of like cancer therapy figured out what was going on. They said mTOR1 was very, very, very sensitive to rapamycin. So as soon as you took rapamycin, it dissociated mTOR1. mTOR2 was 1,000 times more resistant. But your body couldn't put the little parts together that made mTOR2 in the presence of a high blood level of rapamycin. So that's why in transplant medicine, they were taking it every day, because they wanted to knock out mTOR2, because mTOR2 was what was required to knock out T cell function. So T cells would be so deranged in their function, they would not recognize and kill a foreign kidney. And just about the same time, there is another very important paper, Joe Nanick. So she published this paper Christmas Eve, 2014. And this is for like a landmark paper, because what she shows is she gives her rapalog Everleos to middle-aged people for like 6 weeks. She stops for 2 weeks. Then she challenges them with the flu shot, and they have a better reaction. So it's like, rather than sort of like rapamycin having a bad effect on the innate, on the acquired function of T cells and B cells, it was having a better function. It was having an anti-aging effect on sort of older people. So she was like basically the one and first only person to do a real clinical study on humans and rapamycin and she did it with the flu shot, and she showed it improved their immune function. But she showed something very, very else of extreme importance in this study. She said the side effects were related to the nadir level, means the lowest level before you knew dose. So if you took it every day, you had a high level, you'd have side effects. But if you took it once a week, you have very few side effects, because the half-life was like 65 hours of rapamycin. By the end of the week, you have a very low level and so forth. Taking it once a week looked like it was something that could reduce mTOR1 and not mTOR2. mTOR1 is the sort of like part that you want to reduce. That's all the benefits of reducing mTOR1. mTOR2 is like the third rail that you never want to reduce that it causes harmful effects. So the whole idea was to figure out that mTOR1 was sensitive, mTOR2 was resistant, but your body couldn't put together the little parts that made mTOR2 to the competitive inhibition in the place of a high blood level. So it looked like if you wanted to take it for anti-aging, the way to take it was intermittently.
Right. So half-life, Michelle,
Yeah, what does
Yes.
half-life mean?
You know,
it means
half-life-
it's, go ahead, Dr.
half-life
Green.
goes on a logarithmic scale, but it's basically the amount of hours it takes for half of the drug to be metabolized. So if you have something that's 2.5 half-lives, by the end of 2.5 half-lives, you're at a very low level. By the end of 5 half-lives, you're theoretically at like a 0 level. But 2.5 half-lives gives you a very low level that wouldn't be clinically significant by blocking your body from making mTOR2. So that was the idea, intermittently. And Ragasconi had another paper in which he gave it to like volunteers, and he gave them 6 milligrams, and he showed that 6 milligrams was a therapeutic dose. In other words, 6 milligrams had a significant effect. So based on all this type of stuff, I decided in January 2016 that I would try rapamycin. And I decided the protocol I came up with was rapamycin 6 milligrams once a week. The reason for this protocol is I thought that I was dying of aging. Therefore, I was willing to sort of like do something that no one else had done before. It was uncertain how it was going to turn out. It was just this, the idea of how it would work was like theory, but how it was really going to work if you took it once a week for a year, that wasn't so clear. But since I sort of like figured I was in a bad shape, I figured it was worthwhile. And I was going along with Black-Scholes theory that rapamycin stopped aging, and I was suffering from aging. So,
Dr. Green, I have a question. Do you not think that like people like Mikhail Blagosklani or David Sabatini, these people that working in the labs and knew what rapamycin were doing, you don't think they were maybe getting a little rapamycin on the side? I don't know. I'm not trying to make it sound.
I think they were working out the chemistry of it and so forth. Blagosklani was the first person to say mTOR was driving aging. That was Blagosklani's enormous achievement, the recognition, and he had been studying cancer, but somehow or other, and when you look back at I look back at the data involved in 2006, when he came up with this paper idea that mTOR is driving aging, there's so little data to support that. It's just incredible. He was connecting the dots whenever the people weren't even seeing dots. He was so like, and he was figuring that this is that mTOR is driving aging, and not only that, it's a very radical idea that aging and age-related diseases was the same thing, and rapamycin was stopping mTOR, so is stopping the whole thing. So that was the idea. So based on sort of like the two sort of like the ideas, the idea that I'm dying of aging, and the idea that rapamycin and Blagosklani's idea that rapamycin stops aging, I decided to go ahead with this. And with no sort of like real idea whatsoever about what's going to happen. It's sort of like nothing. So
I have a question real quick. How did you find Dr. Is it Dr. Who is he? Who is
Blagosklani,
Dr. Blagosklani?
he's somebody who's writing papers on aging. So since I'm going through the literature, I sort of like come across different people. And as soon as I read this paper stood out. It's sort of like a giant among everybody else who is not making any sense.
Okay.
So Dr. Blagosklani, though, I think he was a cancer, like the head of cancer at a Buffalo hospital in New York.
What?
Right?
What?
But then he became a big writer, editor for a bunch of different
he was a writer, he was doing research, he was so forth. He had started off in sort of like cancer research. But as soon as somebody came across one Blagosklani paper and they read it, they knew this was something different. So he was like, in other words, he was an absolute giant, and it was very clear from what he was writing. So, so then I go ahead and I take rapamycin. I have like no idea what's going to happen, but I'm basically figuring nothing's going to happen. I'm trying to have a high enough dose so at least something happens. So that's why I chose 6 milligrams. And the first thing I notice is suddenly I'm able to like lose weight. Now this is actually extraordinary because prior to taking rapamycin, I could never get my weight back under 175, and I was fighting a constant battle all my life for trying to be under 200. For a while, I was like, I didn't ever wear any pants because I just wore joggers because I didn't want to buy super big pants. So, but it's like, but as soon as I took rapamycin, things all changed. I came to realize I could weigh anything I wanted to weigh. I was just sort of like losing weight was just no problem. And so after a few months, I was like weighing 170 kilograms. I thought that was great. I was a 70-kilogram man. So I was sort of like extraordinarily impressed with how well you can lose weight. So then I continued taking rapamycin. And it also, at about 4 months, the next thing I noticed is, like, I see the dentist and I don't have any gingivitis. Well, that was extraordinary because whenever I had a dentist, right, I was like periodontal stuff and said, you know, like they clean like 5, 7, you know, they're doing all the numbers. I didn't have any more numbers. I was sort of like, I did have gingivitis. So that was like amazing. So I had no expectation for that. Now I looked that up and I found some people had like models showing rapamycin prevented gingivitis. And then by about the middle of June, I noticed that I felt terrific. I didn't think I had any problems at all. I thought, I said, well, I'm Lazarus back from the dead. I'm like perfect. I've cured aging. I can't believe it. I have totally reversed aging. So I'm just sort of like totally flabbergasted with the idea that I have completely reversed aging, and now I'm feeling great. And now I have no sort of like, I'm like feeling like I did 5 years before. So like at that point, things continued. And then the next kind of things I kind of noticed is I noticed that I'm in a good mood all the time. I just like, it was very subtle. It was very subtle. It's like, I realized it's like, it was a very subtle mood elevator. So whenever I would find these studies, I would then look at the sort of like the basic science studies. I would see if they had anything like that. And I saw, yeah, they had something in mice, that the mice were less anxious on rapamycin. It was having some effect on the chemistry. They could tell they're like mice psychiatrists. They could tell exactly how the mice feel by what they're doing. And they could tell the mice were less anxious, less tense. So that was sort of my thing. And then the next thing I noticed, that was like a little surprising, is that at this point I was going for 5-mile walks every day. And in the middle of the walk, I usually have to pee, which is fairly difficult when you're going for a long walk in the park. But at a certain point, that changed. Now suddenly I could go for a whole 5-mile walk and not have to pee at all. So that was made it very convenient, very nice. And then I looked up some more studies and they were saying rapamycin was having a beneficial effect on the prostate. And then the other thing I was noticing is it just seemed to me that I was thinking a lot better, that things were just seeming a lot clearer. Anyway, so I was wondering how long this is going to continue. Like to say, it was like with Michelle, is this going to like, have a, so forth. But it did. I kept on sort of like doing better. And even the following year, I didn't do anything in the winter. The following year, I took up bike riding. I noticed I was able to cycle a lot better than I was when I stopped. In other words, even though I didn't do anything in the whole winter, when the spring came, I was like better at going up hills than I did the year before I stopped. So that was quite amazing. So at this point, anyway, I decide I'm going to start a rapamycin-based medical practice. And I figured at this time that I would have one patient a month. In other words, people who were sort of like what I would call like fellow travelers, people who had found that the same papers I had studied, they had gone through the same stuff. They sort of like, they're interested in rapamycin, but at this time in 2017, there was zero access to rapamycin if you weren't a doctor. Now, if I wanted to take it, I could just write myself a prescription. but no one else could do that. Now things are quite different. All sorts of like rapamycin nulls and stuff have opened up. There's a black market. People can get it. So in 2017, it was different. There was zero access to rapamycin anywhere, unless you got a prescription from a doctor, and nobody else was giving you a prescription. So I started having a few patients, but I set up my practice to have zero overhead. This is because I was not expecting very many patients. So I just sort of like modified my like living room, and I had a den, and I so forth and so on. I got a desk, I got some chairs, and I had a medical practice. And so things continued that. 2017, 2018, 2019, and it became very apparent that patients were doing extraordinarily well. They were doing unbelievably well. Everybody was like, nobody was like, people were just having much, the effects are so dramatic that people were just very well aware of it. And they was really noticing all sorts of things. And by this time I was following, I knew much more because I had been studying all this time. So I knew much more than when I started this whole thing back in 2016, 17 started. So now things are going along very nicely. I have maybe 200 patients or so. And then I have occasion, I have medical insurance. And now I have occasion to have an echocardiogram. And the echocardiogram was mind-boggling. The echocardiogram showed that I had a very severe cardiomyopathy. See, I had caused extraordinary damage, anatomic damage to my heart. That the rapamycin had stopped the disease process, and because it stopped the disease process, it kind of stopped all the symptoms, but it didn't reverse the anatomic damage. The anatomic damage is still there, and the disease was called something apical hypertrophic cardiomyopathy. Well, this was like amazing to me. I was a pathologist. I thought I had heard of everything. I had a disease I had never heard of. So that was quite remarkable. I had a disease I had never heard of. And then I realized this disease was inherited. This disease is what had killed my mother. This disease is what had killed my grandmother. They had both presented it presents with AFib, and they each had AFib, and then they died from strokes. I had developed AFib in my 50s, but I was treated with an anticoagulant, so I didn't have that problem. But I could see that the disease was cooking since 50 years old, for 20 years before it developed its symptoms. But this represented an extraordinary mystery to me. The extraordinary mystery was I was completely wrong about everything. I didn't have aging. I had a totally different disease. If I had aging, I never would have gone into like treatment because I understood by then that the aging would have presented very slowly. And it would have presented so slowly that it would not have alarmed me to think I was dying. It would never sort of like made me start studying an intense study of aging and studying all this then. I never would have done that because it would have been a very slow thing. It never would have motivated any change in my going to do that. Also, if I was suffering from aging, the stuff would have been so mild, so I would never have taken done something that was with that taking rapamycin when no one else had taken it, like something real risky like that. The only reason I was doing that is because what I had was definitely very, very severe. But the other thing is if I knew what I had, I never would have treated it at all. Because if there was absolutely nothing in the medical literature to suggest that rapamycin was a treatment for this condition. So if I actually knew what I had, I never would have treated it. I simply would have realized the extent of the damage. I simply would have seen a top cardiologist in this condition at New York Hospital. And that's what I see now. There's absolutely no treatment. They just would have followed it unless I had heart transplant. And that was not going to happen. So it's like it was just pure serendipity that all these things that I was mistaken about all these things, that rapamycin actually did turn out to be a very good treatment of aging and did turn out to be a very good treatment of my condition. Although I did have a lot of aging things. In other words, even though my main symptom was the heart condition, I still had all the other things of aging because I was 72 years old. So I had all sorts of other things related to aging, which that it was really treating. Okay, so then I was like wondering, this sounds very, very peculiar. But over the years, I realized it was not so peculiar because over the years, I've come to realize that there's thousands of rare diseases. And of these thousands of rare diseases, 5% people have some kind of rare disease. Of these thousands of rare diseases, maybe like 7,000 of them, rare diseases that present primarily in older people, there's a very good chance that mTOR is at the middle of the disease. So mTOR is either starting the disease or promoting the disease. Basically, it was just like I was playing with a stacked deck. A stacked deck was my favorite, in that I would just describe it as if you set up a dartboard and listed 5,000 different diseases, rare diseases that people frequently get when they're older, and closed your eyes and threw a dart at the dartboard and hit the dartboard, there's a very good chance you would actually hit a disease that mTOR is at the center of. And I see that because in my practice, people come to me with all sorts of very rare diseases I have absolutely never, ever heard of. And I generally look up the disease. And I study what the sort of like people doing basic science who have studied this disease have figured out. And more often than not, they have said mTOR is at the center of the disease, and they recommend, oh, people should try rapamycin to treat the disease. Of course, it never happens because it's a generic drug. But so it was basically rapamycin simply treats a whole lot of different things. And so this whole thing was like pure like serendipity. But it turned out to be, without all these mistakes, it never would have happened.
Well, thank goodness it did, Dr. Green, because we're all benefiting from your serendipitous situation.
But yeah.
I have a quick question about your cardiologist. Surely he has seen your change. I mean, from going when you first, well, you were already on that path by the time you saw the cardiologist because you waited until you got health insurance.
As soon as I had the echocardiogram in 2019 and saw what I had, I immediately looked up the top cardiologist at New York Hospital and went to see him.
Right. And
I've
so
been seeing him since 2019, and he's been saying everything has been stable, no change.
okay,
So,
and he's aware of obviously of your rapamycin practice
right.
and what
He's
you're
totally
using it for. And how does he have a feeling about it, or is that something you not want to comment on?
He's New York Hospital. He's the head of the department. They don't use anything unless what that drug is proven by a clinical study. So he's very familiar with rapamycin. He has treated heart transplant patients. He's very familiar with it. It's just he's not in a position to use it because they don't use something. He's, in other words, he's the head of the head. It's like you can't, it's like at New York Hospital,
Right.
you don't do things unless there's a clinical study proving that it works.
True.
Mhm.
But as he said, like wink, wink, great job, Dr.
He's very happy with my treatment. He says I'm doing very well, and there hasn't been, and he sort of like, he says, like, you're doing very well, and there hasn't been any change, and I go, all the things you're doing is great. But he just follows me. He says it, MRI, echocardiographs, and so forth. He has never had 1 ounce of treatment to suggest about anything I was doing. He just follows it. But it turned out remarkably good. Now I have 1,300 patients, and they just are doing extraordinarily well. They're just doing extraordinarily well. And after 7 years of following these people, it's very clear about the incredible effect that rapamycin is having in so many diseases. Most of all, how well it treats people who are APOE4 positive with either 1 allele or 2 alleles. Those people are doing beautifully. They appear, I have 100 people who are double E4 positive, 700 people who are 1 E4 positive. They're not having any cognitive decline. They're not any different than anybody else. They're doing remarkably well.
How old would you say your average patient is? Because in my situation, I don't know it for sure, but I believe my dad and my aunt, who both died around 70 and had Alzheimer's heavily in their 60s. And my other aunt is ApoE double. She's got 2 copies of the gene. She's actually doing perfectly well. We don't see anything, and she's around 80. So it would be interesting to know, like, the average age of your patients that are doing so well.
The average age, I think I would say 40 to 75, with some people as young as 30, who have some specific genes and gene, and some people in their 90s.
Mm-hmm.
But the point is, they're not having any early signs. In other words, before, like 5 years before people developing dementia, it's clear that they're having some problems. That they're sort of like, people aren't getting diagnosed with dementia until they walk out of the house and they get lost.
Right.
Prior to that,
Right.
they could have some very, very significant decline and still be sort of like functioning and walking around, maybe running for president. It's sort of like,
Running for president.
but people can be doing very well in the early stages. But generally, that's sort of like the age range is that people with 2E4 alleles, they have 15 times greater onset, or 15 times greater risk, and an age range of 63 to 75. People with 1E4 have a median onset of 75. But the thing is, the people who are E4 are only 20 to 25% of the population. They develop the great majority of cases of dementia prior to age 80. So dementia tends to be a disease that's presenting at old age with people who are not E4, and frequently in middle age at E4 people. So that's why it's so catastrophic, because it's not to just increase risk, it's the age of onset.
Right. Yeah, that's probably.
Well, I don't know. I don't know how much more we'd like to go into. This is our first podcast, and I want to invite people who are watching this to write their questions in the comment section so we can have a springboard for future discussions.
Well, I wanted to take this time to thank you and Elizabeth, Liz, very much for sort of like, participating in this, having to put together this, and also thanking all the Raptors. because without those people, without the sort of like, in other words, like 1,300 patients, without those people who had the courage and the intelligence to review all the scientific literature, to see, and then they had the courage to go ahead with their convictions and go ahead with something that was completely off-label and outside of regular medicine. We wouldn't know anything about rapamycin if it wasn't for treating human beings. If, like, in other words, if they were just still giving it to mice, there'd be very, very little known about it. So
Right.
I would say the major thing that's known about it is because of the very large number of human beings who have been treated. And their experience is extremely important.
Yeah,
Right.
that'd be really great if we could get some people interested in joining us for one of these interviews sometimes and get some patient testimonials. I see a lot of them on this, Facebook page where people are taking it, and they really are all very, very pleased. And I don't know if they're where everybody's getting it. I know a lot of them are not your patients because of the kind of questions they ask. So I know if they were your patients, they would have the answers to those things. But yeah, it is a little scary. There was one person who was making the comment about taking rapamycin every day. And a couple of people were like, well, for anti-aging or longevity, you really need to take it just once weekly. And I said, you'll suppress your immune system or something. And then she's like, well, I want to suppress my immune system because it's some autoimmune disease. And I guess I don't know, she's trying to do this all by herself. And
Well, it's a very complex drug. It's hard to sort of write to it by yourself. And the idea, it used to down to is rapamycin is a very, very potent prescription medicine. People could already get it prescriptions. Now all sorts of like rapamycin pills has sprung up twice the sort of like black market. So if people want to get rapamycin, they can just get rapamycin without having any real idea of how they should be using it. Two groups, this sort of like rapamycin mills in which you like call up and they have a doctor on sort of like staff and they take some sort of like a little history and then they send you like the medicine. And they're sort of like, they're treating it like it's a supplement, right? You just get it and figure out how to take it yourself. That's one group. And then there's another group outside of the law that don't require any prescription. It's just a black market that's operating early.
And I guess you really never know what you're getting if it's black market, really, but most
You never
likely.
know. And while we're on this topic too, this isn't, your intention, Dr. Green, is really just to educate people. It's not about your practice. It's not about growing your practice. It's really more getting the information out there.
And yeah, my base barely have as many people, there's not more people that I can see. So the idea of the podcast is for people to understand rapamycin, to understand aging, to understand the age-related diseases. That's the idea of it. The idea of it is to create a demand and thousands of other people so that we somehow have 10,000 doctors prescribing rapamycin, and to change the focus of medicine from waiting for the business model of waiting for people to get sick and then treating them after they get sick, and generally without very good success, to keeping people well.
Well, that's really our model of healthcare as we know it. It's a sick model, not a
right,
wellness model.
exactly. Right, people get sick and then you treat them. The idea of like, you keep people well, and then that's a totally different idea. I mean, you can see that very, very strongly with APOE4. There's no movement to treat asymptomatic APOE4 people, besides from like my practice. They're just sort of like ideas like, wait till you get demented and then We'll see, we'll deal with you. That
Then we'll
doesn't,
give you a drug that doesn't work to treat you.
right, yeah, in
Right.
other words, waiting until you get this, like, in other words.
A really
eventually-
expensive drug that doesn't work.
Right, yeah, so it's like, yeah, it's like, it's a very expensive drug that doesn't work. That's the business model. The business
Mhm.
model is not prevention. Very good.
Well, what, is there anything else, Dr. Green, that you want to say as we kind of wrap things up?
No, just the support to all the Raptors who have sort of like had the courage to sort of like get treatment before it was some proven with a clinical trial that was never going to happen.
We'd be waiting forever.
Right, the idea is that perfect is the enemy of good. So we're going for what's good.
And that's what we're going to say about this podcast. Perfect. If we don't post it because we're not, as shiny as we like or whatever, then that would be perfect is the enemy of good. So, okay. All right. I guess-
Bye-bye.
Bye, everybody.